My name is Leigh Finnegan. I am a fourth-year med student, and I am a USMLE tutor and a content creator for MedSchoolCoach. And our question of the week this week is for the USMLE Step 1 exam, although it does have some kind of Step 2 elements in there. So here's our question. A 27-year-old female presents to the emergency department with a complaint of chest palpitations and dizziness. Her past medical history is notable for generalized anxiety disorder, for which she takes sertraline daily. Her heart rate is noted to be 175 beats per minute, and her blood pressure is 106/74 millimeters of mercury. Her EKG on presentation is shown below. The patient is given an IV dose of a medication which is intended to quickly break her abnormal rhythm. A few seconds after the medication is given, her EKG shows the following. What is the mechanism of the medication that was most likely administered between these two EKGs? A, hyperpolarization of cells in the atrioventricular node. B, blockage of sympathetic input into the sinoatrial and atrioventricular nodes. C, blockage of sodium channels in cardiac myocytes. Or D, blockage of calcium channels in cardiac myocytes. Now, this is a typical STEP question in that it contains a whole lot of information that is not necessary for answering the question. And it kind of highlights the importance of looking at what the question is actually asking you to figure out what information you should be thinking more about and what information you can kind of ignore. So for this question, let's kind of work backwards. It's asking, what is the mechanism of the medication that was given? So it's not asking you what is the medication, but to know the mechanism, you probably need to know what medication it is. Maybe for this one, you might be able to use some process of elimination and get down to one or two answer choices, which we'll talk about a little bit. But in general, you need to know the mechanism of the medication. And so to do that, you need to know the medication. So to know what medication you're giving, you need to know what condition you're treating. And the condition that you're treating is the abnormal heart rhythm that she's presenting with in the first EKG. So what the difference between the first EKG and the second EKG is telling us is essentially that the medication worked in breaking her arrhythmia. But it doesn't really matter what her underlying diagnosis is. That would be something that you would look at, you could look more at the second EKG if you were interested in that, but that's not really what the question is asking. So we just want to know what's the abnormal rhythm she's in, so that we can figure out what medication we should give to break that normal rhythm, and then we can figure out what the mechanism of action of that medication is. So let's start by taking a look at her EKG on presentation. And let's go through this. So, is she tachycardic or bradycardic, or neither? She's tachycardic, right? And they gave that in the question stem, right? That her heart rate was about 175 beats per minute. But using our big box method, if we've got the difference between, ooh, that was terrible, the difference between like this beat and this beat right here, it's less than 2 big boxes, but more than 1 big box. So between 1 and 2. So 1 big box would be 300 beats a minute, 2 big boxes would be 150. And so between this, in this one, it's kind of in that between 150 and 200 range. So it's tachycardic. Is this sinus tachycardia or non-sinus? Well, sinus would be a P after every QRS and a QRS after every P. And sinus tach looks a lot like a normal EKG, just that's going a lot faster. You'll have P waves, QRSs, etc. We see QRSs here, but we don't really see P waves, right? So this is not sinus tachycardia. Another hint is that since it's 175 beats per minute, that's very fast for something to be sinus tachycardia. So this probably isn't sinus tachycardia. So where is the tachycardia coming from, if not from the SA node, like a sinus rhythm would be? Well, let's take a look at some more features of it. Is this a regular or an irregular heart rate? It's very regular, right? If we march these out using a caliper, these are all pretty evenly spaced, these QRSs between each other. These distances are all pretty much the same. So that tells us that this is a regular tachycardia. And is this monomorphic or polymorphic? It's monomorphic. These QRSs all look pretty much identical to each other to me. So this is a monomorphic tachycardia. And finally, is it wide or narrow complex? This is really key. So it's a little hard on this screenshot that I've got here, but you can see kind of, QRS starts here and ends here. That's definitely within the range of a normal QRS duration. That's not a prolonged QRS duration. So it's a narrow complex tachycardia. So what we have is a regular, monomorphic, narrow complex tachycardia. Where does it sound like that tachycardia is originating? Is it above the ventricles or in the ventricles? It's above the ventricles, right? And that word pretty much tells us based on these narrow complexes, right? Because SVT, supraventricular tachycardia, the ventricles are, for the most part, not always, and we'll talk about one case in which that's not true, but for the most part, the ventricles are being depolarized normally because the abnormality is occurring above the, at the AV node or above. So the ventricles are seeing normal depolarization. It's just going much faster than normal. So we wind up with QRSs that are narrow, complex, and look pretty much normal. So this person has supraventricular tachycardia. What drug do we use when someone has symptomatic SVT? What drug do we use to break SVT? Adenosine. We use adenosine to break SVT. Now, why do we use adenosine? Because of the mechanism. So the way adenosine works is that it increases potassium efflux from the cell at rest. So if here's our cell, the way our membrane potential is normally determined is largely by potassium conductance, right? We've got potassium that's going from inside of the cell to outside of the cell. So we're moving a positive ion from in to out, resulting in a negative membrane potential. So the inside of the cell is negative as compared to the outside of the cell. If we increase that potassium efflux, that means we've got a whole bunch more potassium ions that are now moving out of the cell. So what's going to happen to our membrane potential, our VM? It's going to get a lot more negative, right? Because now we have even more potassium moving out of the cell. So we've got even fewer positively charged ions inside the cell. So that's going to give us an even more negative membrane potential. This is going to hyperpolarize the cell. Remember, polarization is how far away from zero it is. So, here's 0 on this graph here. We're going from, in a normal pacemaker potential cell, such as in the SA or the AV node, we're going to have a membrane potential of around negative 60-ish. Here, maybe it's going to be all the way down here, like negative 80. So when we have this hyperpolarization as a result of blocking, of increasing that potassium conductance, we're starting out from a much lower level here. So to reach our depolarization, our threshold for depolarization takes a much longer time, right? Because we're starting out so much lower. And then because of that effect, because of the effect on the potassium current, our rapid depolarization, which is calcium mediated, also occurs much slower than it normally does. Remember, this happens in pacemaker tissues. It particularly affects the AV node, because so remember, pacemaker polarization happens in the SA and the AV node, but this particularly affects the AV node, such that it affects the cells of the AV node so much that it actually induces transient complete heart block. It completely blocks conduction through the AV node in those cells. Now, inducing third-degree heart block or complete AV block is not a great idea. That's why this has a very short duration of action, because it blocks, and it blocks for a few seconds, and then it comes off, and the heart goes back into its rhythm. Breaking those, blocking through the AV node is great for diagnosing and breaking supraventricular tachycardia. Now, why is it good for diagnosing and breaking supraventricular tachycardia? Well, because the whole point of an SVT is that it's coming from somewhere in the AV node or above. So if we block the AV node, we're going to block the pathway that reentrant circuit is taking, and we're going to halt that circuit, and we can get back into normal rhythm. It's not going to work for something like VTAC, because VTAC isn't utilizing the AV node in order to create the tachycardia, so blocking through the AV node isn't going to touch your reentrant circuit. So the particular kind of SVT that this person has arises from WolffParkinsonWhite syndrome, which we can tell because on this second EKG, we can see these delta waves right here, where instead of going perfectly up at a right angle like this, it kind of slopes upward more gradually. And that's because there is an abnormal connection between the SA and between the atria and the ventricles. So normally, an impulse goes from the SA node, down the internodal tracts to the AV node, down the bundle of His, to the right and left bundle branches, to the Purkinje fibers, to the rest of to the myocytes. And there's normally only one connection. and it has to go through the AV node to get from the atria to the ventricles. In WolffParkinsonWhite, we have an abnormal connection between our atria and our ventricles. Something like this. We have an abnormal electrical connection between the atria and the ventricles. So that's what gives us this delta wave, because the AV node pauses. So during a normal beat, the impulse travels from the atrium to the AV node, then it pauses, then it goes here. In someone with WolffParkinsonWhite, it goes to the AV node and also to the abnormal pathway, and that gives the ventricles a little bit of early depolarization, resulting in that sort of upstroke, in that sort of swoopiness over here, this kind of more gradual curve here, instead of what we would see in a normal EKG, which is like this. It would be more like this. That's the delta wave. So that's what we're seeing there. What happens when we have, what happens when we have a perfectly timed beat is that we wind up with a reentrant circuit, where we have an impulse that's traveling from the AV node down the normal pathway, and then back up the abnormal pathway, coming back to the AV node and doing this. Atrioventricular reentrant tachycardia. It can also go the opposite direction, where it goes down the abnormal pathway first and then comes back up. That would give a wide complex tachycardia. That would be antidromic. That would give a wide complex tachycardia because it's going down the abnormal pathway first, and therefore the ventricles are seeing abnormal repolarization. Not what's happening in our case here, because our person has a narrow complex tachycardia. But it wouldn't actually matter, because the point is, a great way to treat this is to block the AV node. Now we've blocked part of this loop. So when our impulse goes around again, it's going to go down and back up, and then it's going to get here to the blocked AV node, and this reentrant will stop. Because by the time it's able to get through, the timing of the refractory period will not be, it won't have that perfect timing of the cells being no longer in the refractory period by the time the impulse gets to them. So for that reason, this will block our reentrant circuit, and our next beat can hopefully go back to being a normal sinus beat. So that's what happens here. That's why we give adenosine in order to treat supraventricular tachycardia, because supraventricular tachycardias must go through the AV node, and it causes block in the AV node. And the way it does that is through question A, answer A, which is hyperpolarization of cells in the AV node. Now, if you didn't know that you were supposed to give adenosine to treat SVT, you could kind of figure this out, because you can figure out that blocking your AV node is probably going to be a good idea when you have someone with SVT for all the reasons that we just described. So the questions that have blocking cardiac myocytes, blocking sodium or calcium channels in cardiac myocytes, aren't really going to help you with this quite as much, because what you really want to do is blocking the node. So you can kind of, so you can kind of cross out those ones. Question B, answer B, blockage of sympathetic input in the SA and AV nodes. That's a beta blocker that it's describing there. And that's also not going to be, theoretically could work, but is not nearly as effective as adenosine for really quick, really instantly, and very effectively breaking a supraventricular tachycardia. So that is the answer to this question.